I'm going to talk about how big of a problem is PAD and what does it cost. First, the SAGE Group is a for-profit research and consulting company. Whoops. We sell our products and services to industry. The clients in gold are those in the last 12 months. According to the diabetes method, between 18 and 19 million people have PAD. That's prevalence. That is not the number treated. It's a tiny fraction that's treated. 17 to 19 million is considerably higher than the most commonly quoted estimate of 8 to 12 million, the Criqui Partners estimate. Now, why is that? This was a good estimate for 1995. That was 20 years ago. And since then, the U.S. population has aged and become considerably more diabetic, particularly in those 65 and older. Note that the diabetes method estimates 11 million for 1995. Since 95, the prevalence of diabetes has almost doubled in two key age groups, the 45 to 64-year-old age group and 65 and older. Currently, 36% of the elderly have diabetes, and 18–19% of those 45 to 64-year-olds have diabetes. Based on these trends, the future looks pretty grim. By 2040, over 50% of the 65 and older group will have diabetes. Age and diabetes are significant risk factors for PAD. If we look at the 40 to 59-year-old age group, 3% have PAD, but in the 70-year-old plus, 19% have PAD. PAD is more prevalent in diabetics. In the 50 and older age group, 10 to 20% of those with normal glucose have PAD, but 30 to 40% of diabetics will have PAD. Updating the Criqui Partners estimate for the 2010 U.S. population by age group, we see 10 to 17 million. We have a new estimate here, which is based on a recently published study by Nealer, and the estimate is 17 million, and both of those estimates are in line with the diabetes method estimate for that year. Looking at prevalence over time, from 11 million in 95, 18 million today, by 2030 we could have 24 million people with PAD in this country. The prevalence of other diseases, PAD is only exceeded by diabetes at 26 million. There's about 1 million more than CHD and a lot more than Alzheimer's, stroke, and even cancer. Looking at the annual economic burden, between $164 and $290 billion are spent annually on PAD. These are inpatient and outpatient costs in the REACH registry, the lower number, and in the Margolis managed care study. The key difference between these two figures is that the REACH registry looked at cardiovascular hospitalizations only, whereas the Margolis included all-cause hospitalizations. Hospital costs do represent the majority of costs, between 62 and 87% of costs, or $102 billion and $253 billion in the Margolis study. Two Medicare studies also found that almost 90% of the costs are inpatient. In contrast, only 31% of healthcare expenditures are inpatient. The non-PAD costs are significant. If we look at cardiovascular hospitalizations only, 43% are cardiovascular, they're not PAD. If we look at all-cause hospitalizations, 90% of those costs are not PAD specific. So who pays the PAD bill? Medicare and Medicaid pay over 80% our tax dollars at work. Turning to PAD patients in Medicare, 7 to 10% of Medicare patients are treated for PAD. Average cost per patient is $25,000 to $63,000. The key difference between those two estimates is that long-term care costs are included in the higher figure. Note that above-the-knee amputation is the third most commonly performed procedure in Medicare patients. Annual expenditures at $63,000 for a PAD patient, that's 6 times the average expenditure of $9,800 for the Medicare beneficiary. Turning now to the interrelationships among diabetes, critical limb ischemia, diabetic foot ulcers, and major amputation, and how these impact the costs of PAD. Diabetes is highly prevalent in CLI. Up to 80% have CLI. In contrast, only 13% of the U.S. population has diabetes. Looking at the impact, diabetics present with more severe ischemia. Diabetics are more likely to present with tissue loss. There are more amputations and a higher risk, 28 times the risk. The risk of amputation increases with the severity of diabetes. The rate of amputation increases with age. The majority of CLI amputations are associated with diabetes, and 85% of amputations are preceded by a diabetic foot ulcer. There are about 4 million prevalent DFUs, and the majority, 65%, have an ischemic component. They're either purely ischemic, only about 15%, or 50% have a combination of neuropathy and ischemia. Why is ischemia important to a diabetic foot ulcer? They cost more. An ischemic ulcer costs in excess of $35,000. A non-PAD ulcer costs about $8,000. Ischemic ulcers cost an estimated $61 billion. We can argue that those costs should be included in the cost of PAD because unless these patients are revascularized, these ulcers will not heal. If we add that to the figures cited before, the total cost of PAD becomes a staggering $225 to $351 billion. So the conclusions, PAD is highly prevalent and commonly underestimated. The macroeconomic cost is very high, 164 to 290 billion. Hospital costs do account for the majority of those costs. Hospital costs are significantly increased by cardiovascular and non-PAD events, and the hidden costs of CLI DFUs increase the total cost to $225 to $351 billion. So my staff and the interns, we thank you.